introduce you guys to a friend of mine, Dr. Alec Lindley. Dr. Lindley is a native of Port Lavaca, Texas, and he graduated summa cum laude at McMurray College in Abilene, Texas, where he earned his bachelor's degree in chemistry. He attended University of Texas Southwestern Medical School, where he received his doctoral medical degree. Dr. Lindley is certified in internal medicine and infectious disease by the American Board of Internal Medicine. Dr. Lindley began his career as a solo practitioner in Amarillo, Texas in 1982. He is currently in practice with a group of infectious disease physicians in Little Rock. The name of his office is Infectious Disease Resource Group. Dr. Lindley is also an author of multiple infectious disease-related articles in the national medical publications. Dr. Lindley's presentation objective is to discuss the new HIV treatments. And I would like for you guys to help me greet Dr. Alec Lindley.
Can everybody hear me?
Yes.
Even in the back? No? Can you hear me now? Still no? Can you hear me now? Okay, so I had to stand here. Uh-oh. So I wanted to start by telling you a little bit of how I grew up with HIV. When I was a third year medical resident, this was about fall or spring of 1982, I saw a young man with hemophilia who we didn't know what was wrong with him, but we knew he was dying, and we knew that he had several things that a young man his age wasn't supposed to have. And then I went on and read about him later as one of the first hemophiliac young men to be shown to have acquired immune deficiency syndrome, or AIDS. That's fortunately a long past situation, but early on, hemophilia was one of the risk factors for having HIV, because the young men, basically all men who had hemophilia, were getting it from their factor transfusions before they could screen for the virus. Yeah, in fact, they had the 4 H's at that early time. It was heroin use, hemophilia, homosexuality, and Haitians. The times have changed some. Not long after I got into practice, and Cheryl mentioned that was 1982, I saw reports in the MMWR of young homosexual men in New York and Los Angeles who were getting pneumocystis pneumonia. And I was in Amarillo, pretty far from either Los Angeles or New York at that point, and didn't see any people with HIV then, but heard something about the strange new developments that were going on. I was in the Navy for a couple of years, and then in practice again in West Texas and San Angelo around 1986, when I saw the first patient that I knew had HIV at the time I was seeing him. He had been somewhere on the West Coast and basically had come home to die. A very sick, sad young man who'd come back to San Angelo because that's where he'd grown up. The two things that I remember about him are that my associate who was seeing him was so afraid that he was wearing what was a close approximation to a hazmat suit. He had on a gown, he had on gloves, he had on a cap, he had on a mask, and he had on shoe covers. I mean, he put on everything that he could find to put on for this poor young man who was dying of HIV/AIDS. And the other thing I can remember is how severely, impressively ill this young man was. Then I went to become an ID, infectious disease fellow, in 1988, and saw and had my first opportunity to treat HIV, and the only drug we had at that time was AZT, which came out in 1987. And in those crazy early times, we would ask people to take AZT every 4 hours while they were awake because of some considerations of how long it lasted in plasma. Fortunately, it lasts longer in cells, and as we figured out later. So these men, mostly, they were all men that I was seeing at a VA in Virginia, were somehow complying with taking a pill every 4 hours while they were awake, five doses a day. Well, it worked a little, and it worked for a while. I also learned at that point to begin to how to follow CD4 counts. CD4 counts, as y'all may know, are the cells that the virus attacks, and the number of those cells that you have correlates with how much the virus has affected your immune system. And what my patients were experiencing is that their CD4 counts would go down and down. AZT would help a little bit for a while, sometimes a few months, and then it would go down. And then we didn't have anything else to do except to try to prevent their infections as they got sicker and sicker. Between 90 and 95, I was in practice in Dallas and took care of a number of very nice young men who had HIV and then got AIDS and then died while I was taking care of them and not able to do nearly as much as I would have liked. I also remember a woman that I saw from a town 60 miles north of Dallas who first found out something was going on with her husband when he got pneumocystis and died in a few days in the hospital. And she, on testing, had HIV too, HIV also. And she really touched my heart. She was such a sweet, sort of nearly purely innocent woman who had gotten this through no action of hers, and she did not last very long either. She was dead within a few months. So it was a hard thing to have, obviously. It was even a hard thing for people like me to take care of at that time because everybody died. It was like getting a diagnosis of cancer. You treated it, you did your best, some treatments sort of worked, and eventually everybody died. In December of 1995, the first protease inhibitor became available, a drug called sequinavir. And then in March of 96, some better drugs became available, ritonavir and indinavir. And the change was actually pretty quick and pretty remarkable. People stopped getting worse. You know, if they would take their medicine and we would give them a combination of medicines, they started getting better. And it was remarkable and wonderful to be able to go from presiding over people's slow death to offering them something that actually got them better. Some other drugs came out after that, but I think what I'd like to try next is to use this sort of cartoon drawing to talk a little bit about how this virus works and how the medicines that treat it work. So you see up there in the upper left-hand corner this cartoon drawing of an HIV virus. And it's coming in and attaching to the cell, and there are actually several cells that HIV can infect, but CD4 cells, also called T4 cells, in the past we used to just call them T cells, also called helper lymphocytes. Those are the most important cells that it infects and attacks, so we'll say that's a CD4 cell. It comes in, and first it has to attach, and there are some important steps there, and then it fuses with the membrane of the cell. You can see where it's sort of dissolving into the membrane of the cell, and then the insides of the virus are dumped out into the cytoplasm, the main compartment of the cell, and the nucleic acid of the virus, which is RNA, ribonucleic acid, is dumped out there. There's an enzyme called reverse transcriptase which copies that RNA into DNA. And they call that reverse transcriptase, and in fact they are also called retroviruses because this is sort of reverse of the usual sequence. In a human cell, the information is stored in the nucleus as DNA. And the way that usually works is RNA gets copied from the DNA, goes out to a ribosome, and makes a protein. So it goes from DNA to RNA to a protein. But this was going backwards. It was going from RNA to DNA. So I think that contributed to why it was a little hard to find at first. That contributes or explains why they call it a retrovirus, because this is a backward direction of the copying. And that enzyme that does that is reverse transcriptase, which turns out to be one of the main enzymes that we target when we treat. And that's important because human cells don't have reverse transcriptase. That's something that we can attack on the virus that doesn't bother humans so much. When the RNA is copied into DNA, it goes into the nucleus, this part up there, and it gets integrated into the DNA of the human cell. And that's an important step and important ability of HIV, because once it gets put into the DNA of the cell can't get rid of it. And there are some cells that can live a long time, long-term memory cells, that can carry this virus around integrated into its DNA for maybe as long as a few years. Then at some later point, and probably oftentimes not very long, the DNA that's in the nucleus gets translated back into RNA. Remember, that's more like the usual process. DNA to RNA moves back out of the cytoplasm to a ribosome, and the RNA is read, sort of like a code. It's read and made into proteins. And then, through ways that I can't explain, the cell and inside the cytoplasm, those parts of the virus are put together into a virion, a virus particle. And then they call that assembly there. You can see it comes down and it goes to the cell membrane, and it sort of buds out of the cell membrane. And the proteins that are inside there at that point are actually big, long, polyprotein strands, multiple proteins in one place. And then there's another enzyme called protease, which breaks that big polyprotein down into the proteins that the virus actually uses and needs. So this shows you how the virus attacks and goes through a cell, but it also shows you the places that we can attack the virus. There are a couple of drugs that can interfere with the attachment of the virus to the cell. There are quite a few drugs that we have that try to inhibit that reverse transcriptase enzyme. There are a couple of drugs now that can interfere with the integration of the virus DNA that came from the RNA into the chromosomes of the human cell. And then there are several other drugs that inhibit the protease down here in the lower right corner, the protease that breaks up those big long polyproteins into proteins that make it a successful reproducible virus. Hopefully I didn't just put everybody to sleep. So that shows you how it works and where the drugs work. In '96, there was a drug released called nevirapine that also worked on reverse transcriptase, but it was unlike the earlier drugs that were called nucleosides. Just that's the chemistry of it, but they work on the same enzyme. In 2003, there was a fusion inhibitor that blocked the fusion of the virus with the cell surface. In 2007, there was another drug that worked a different way on trying to block the fusion. And also in 2007, the first integrase inhibitor that blocks integration of the DNA into the nucleus came out. So we have several different kinds of drugs now, and in a couple of those classes, the nucleosides and the non-nucleosides and the protease inhibitors, we have multiple drugs within that class that may work. One of the things that has to do with this that I was going to try to use an illustration on is the problem that we have with resistance. And I want you to think about the next great University of Arkansas basketball player that you're going to find. Arkansas has about 2.8 million people. So we're going to try to come up with this great player who's a 1 in a million, or maybe 1 in less than a million. First, we want him to be 7 feet tall, okay? So, well, that's probably 1 in a million or something like that. Oh, but we also want him to be actually able to run and dribble, and in fact, we're going to make it harder than that. We want him to be an extraordinary athlete. And we're going to say we want him to be so extraordinary as an athlete that we want him to be 1 in a million as an athlete. And then we're going to say we want him to be really smart too. He's got to be 1 in a million smart so he can actually pass the classes at Fayetteville while he's going to Hoops Glory in the basketball arena. So he's got a 1 in a million height, a 1 in a million athletic ability, and a 1 in a million brain. And at that point, you say, well, there's probably not anybody in Arkansas like that. This is a little bit like what we're trying to do to prevent resistance in HIV. There are an amazing number of HIV virus particles made every day. It's something in the range of 10 billion to a trillion. You know, more than there are people in the world you make on an average day with HIV if you're not being treated. You also make something like 1 billion CD4 cells a day. I think that was a revelation to me when I first realized that. It's like this high stakes foot race. Your body is producing CD4 cells as fast as it can, but unfortunately those CD4 cells are also producing new virus particles as quick as they can. Well, there's a certain chance of each virus that's made being made wrong. That is, it can have mutations in its DNA and its RNA. And a lot of those mutations aren't good. The virus doesn't live, or it doesn't live well. But you know, if you're making 1 trillion viruses a day and there's a 1 in a million chance that the virus makes a mutation that helps, you still made a lot of virus that could figure out how to beat the one drug. But if we give 3 drugs, it's a little bit like looking for that basketball player who's 7 feet tall and amazing athlete and amazingly smart. That turns out to be too hard for the virus to figure out how to beat most of the time. The odds are too low. That's why we have to use combinations of drugs. If we were just looking for 1 in a million, well, there are a couple of those in the state. But you know, we're looking for lower odds than that to try to prevent the emergence of resistance. When the drugs became available, the protease inhibitors in 2006, then we moved from ineffective treatment to effective treatment. Then we began to have to worry more and more about other aspects of the treatment, like how much this stuff costs and how many pills it was and the side effects that it caused. I can remember one of the earlier non-nucleosides was called Delaverdine. It was 4 pills 3 times a day. It was 12 pills just by itself. And one of the early protease inhibitors, Amprenavir, was 8 pills twice a day. Ritonavir was 6 pills twice a day. People could easily be taking 20 pills or more, and some of those 3 times a day, trying to comply with what we were giving them to take. And as you can imagine, that was pretty hard. And so some of the improvements or steps that we've taken since then are to get to fewer pills and pills that cause fewer side effects. In 2012, there was an update in the treatment recommendations from 2 different bodies, the Department of Health and Human Services and the International Antiviral Society in the USA. And they basically have similar recommendations. And one of the important things that they said in these recommendations is that they think we should start treating earlier. this has sort of gone back and forth for years. For instance, in 1995, there was an idea that we should treat early now that we had something effective to treat. And then the problems with toxicity and mutations, resistance caused us to pause and think. Now the recommendation is that we should think about treating early again. What do I mean by that? We used to wait till somewhere around 500 CD4 cells or sometimes even lower before we would treat. They now recommend that you start treating if the patient is willing to, interested in it, prepared to comply as soon as they're diagnosed, which is a change. You have to take the medicine for the rest of your life. That's a big deal. You have to deal with cost and side effects and things like that. But the medicines are good enough and the recommendations are strong enough now that they suggest doing that. The benefits I've listed here on the left. If you can prevent going to such a low CD4 count, it may have benefits for your immune system. There seems to be some sort of cumulative toxicity of how much virus you've had reproducing for how long. And maybe one of the big reasons from my mind is if you're on effective therapy, you're much less infectious. So taking treatment and treatment that works may help you keep from infecting 2 or 3 or 5 or 10 other people. They have to be ready, as I say, to start it because you don't want to start and stop. That's the way you get resistance. And they have to be able to get the medicine, which at times has been a real problem, and currently it doesn't seem to be as much of a problem. And you have to be able to deal with side effects, which are better than they used to be. These recommendation guidelines have a fairly small list out of the 15 or 16 different drugs that are available. A significantly smaller list are the ones that are recommended. And for various reasons, these are the nucleosides. These work on reverse transcriptase. You often use 2 of these together, and oftentimes that's called the backbone of the treatment. And the 2 that are both recommended are tenofovir and tricytidine, or abacavir lamivudine. They come as the 2 medicines mixed together in one pill, Truvada or Epsicom. There's one recommended in an RTI. There's some others actually that are useful, but in terms of starting treatment and recommended therapy, efavirenz or Sestiva is the one that's recommended. And then there are a couple of protease inhibitors that are recommended with several others that have to a certain extent fallen by the wayside and are not used as much anymore. Atazanavir and darunavir are the protease inhibitors. Ritonavir is actually a protease inhibitor, but it's not there to act as a protease inhibitor. It's there to change the metabolism of the other drug in the liver so that it lasts longer and achieves a higher level. It's just there to change the way the drug is metabolized. And we use it at a lower dose. It was one of the drugs that came out in March of '96. I had one woman who tolerated that fairly well, but hardly anybody tolerates full dose ritonavir because it's kind of a lousy drug in full dose. In the lower dose, it's not so bad. Then there's another drug called a integrase strand inhibitor or integrase inhibitor. That was that step, you remember, where the DNA got mixed up with the human DNA in this nucleus. There's one recommended drug for that called raltegravir. So the first line combinations generally are all tenofovir and tricytidine because that's a potent combination that most people tolerate well, and it's only 1 pill a day or 1 dose a day. And you couple it with one of these other drugs on the right column there, and all of those are first line recommended. Let me leave that for a moment. Finally, there are, probably a lot of you have heard that there's at least one pill that's 1 pill once a day, a drug that's been out for several years now called Atripla. The top one A lot of people take that drug. It's probably the most commonly prescribed drug for HIV. It's a potent drug. Most people tolerate it pretty well, although almost everybody has some side effects at first. A lot of people are on this drug. Complera and Stribild are newer drugs that may also work with certain limitations, and the Stribild is really just brand new, only been out a month or two. I think I've got one guy who's trying that right now. So the gist of the 2012 guidelines, as I take it and as I would present it to you, are that we should think about treating people earlier than we used to. We used to wait because we were trying to balance out the cost and the toxicity and the person's readiness to take treatment versus the benefit. We now think that there's enough evidence of benefit that you should urge people to take it when they're diagnosed, even if they have a high CD4 count or a normal CD4 count. And then the other part of the recommendations, which is not entirely new, is that there are, amongst the larger number of drugs that you can get, a smaller number of drugs that they suggest are the best ones to think about taking first. People who've been on meds for a while can have resistance, and there can be all kinds of reasons why you need to take another drug in a specific circumstance, but these are the recommended treatments. Okay, let me stop and let you guys ask questions. Yes, ma'am.
I want to ask my question. What is going on with those people that don't take any drugs and their what's it,
CD4 count?
CD4 count don't go up, their nose don't go up, nothing?
There are a small fraction of people who get HIV whose immune system handles it better. And one of those groups, a larger group, are called long-term non-progressors. That is, they've had the virus for a long time and it just doesn't make their immune system work. They control it. You can detect the virus in them, but they are able to maintain a normal CD4 count over time without treatment. And 1 or 2%, something like that. It's only a couple of percent. There's a smaller number of people called elite controllers who appear to be able to suppress the growth of the virus. The long-term non-progressors, there's virus growing, but it's just not destroying their immune system. The elite controllers, which is like, 1 in 300 or so with the virus, can suppress the growth of the virus. So, yes, there are a few people who are able to do it like that. It's a small minority. So they
They may not never need medication.
They may not. They still warrant follow-up because I've seen people who I thought were long-term non-progressors that finally their CD4 count drifted down. I have seen people like that before, but with follow-up, it's possible that they won't need treatment.
Yes, sir. Do they have a program for peoples that may be for this trinophoria?
Uh-huh.
Do they have any programs free for peoples without insurance to help, for those that can't afford it?
They do. I have a number of patients in my practice who obtain their drugs through a government program that it has more than one name, I know. The name that I know is the Ryan White program. Ryan White, you may remember, was a young boy with hemophilia who got HIV back in the, I guess, the early 90s and died from that. But they set up foundations and other treatments that related to his name and his legacy. There are funds available through, I think ARCare is the administering agency here, that can allow most people who don't have insurance to obtain the drugs.
Okay, also, is it possible that you can pass that information on?
Yes.
Thank you.
What if the doctor tells you you don't need medication?
There have been perfectly defensible reasons to be told that. And, you know, I would say that just because these guidelines came out, they came out last summer, there may well still be good HIV practitioners who don't necessarily believe that you know, somebody should be treated when they're diagnosed. It's a guideline. People could have reasons of personal preference or experience or other reasons why they would not recommend it. But I think the trend is moving away from that and more towards everybody who finds out considering the treatment. Cheryl.
One of my questions is, what's the number that you see CD4 count? What is that actual number that you primarily see when it comes to?
What is the last, what did you?
What's the average CD4 count that they come to? What number is coming in?
Okay, a normal CD4 count is, you know, if you look at the lab normal range, it says something like 350 to 1500. But we actually are not too happy when CD4 counts fall below 500 in a person without treatment. A normal CD4 count in most of you all is probably in the range of 1,000. But there's a range, and a CD4 count varies from day to day, probably from hour to hour. It's not the same thing. When you drop below 200, then we say you have AIDS, just based on that CD4 count, because that has been shown to correlate with a significant enough problem with your immune system that you're at risk for the various illnesses that that low immune system predisposes you to. So approximately 500 to 1,500 is normal. Less than 200, we would say you have AIDS.
Well, I was saying, what number you see when your patients come in? What number, what's it?
Oh, when I see them first, it's all over the map. I see people who still have normal CD4 counts when they come in now, if they're diagnosed early. I think I've seen several people who, when I first saw them, had less than 10. And some of those people have gotten better and done well, too, I should say. I'm thinking of one in particular. But, yeah, anywhere from less than 10 to normal. Yes, ma'am.
Is there any other, anything else that can cause your CD4 count to drop other than HIV or AIDS?
Absolutely. Corticosteroids, for instance, can drop your CD4 count. Other viruses can probably drop your CD4 count at least transiently. It's a CD4 cell is a cell right in the middle of your whole immune system. And it does a lot of things, and it's affected by a lot of things. And so those things can affect it, other things can affect it too. And usually that's just a temporary thing. Yeah, it was true today, but it may not be true next week. But it is why we try not to overinterpret one CD4 count, because more than one thing can make it that where it was that day.
Dr. Lindley,
Yes.
what do you think is the greatest misconception about HIV now, or the misinformation about HIV now?
Well, I think it could be the notion that it's not a problem anymore. You know, that we've got good treatment for it and people don't need to worry about it. That's at least in the running for the greatest misconception. I think the other great misconception is that HIV can happen to those other people, but it can't happen to me. Yes, ma'am.
What is the difference between the blood count and the viral load? I mean, which one's supposed to be low and which one's supposed to be high?
That's a good question. The CD4 count and the viral load are the two big tests, the two tests that we use to decide how somebody's doing. The CD4 count is a measure of these cells that you're supposed to have and you'd like to have a normal amount of. So the higher the number of your CD4 cells you have, the better. You'd like that to be in the normal range. The viral load is a measure of how much virus you've got in your blood. And on good, effective therapy, that number should be 0 or undetectable. So the viral load you want to be a low number, preferably undetectable, and the CD4 count you want to be a high number, preferably normal. And again, normal is like 500 to 1500. Yes, sir.
What about those who are on the combination therapies, but their viral load goes down, but their CD4 still go down as well?
Well, I don't think I've experienced a situation where CD4 count goes down and stays down on effective therapy. Generally, if you've made the viral load undetectable, then you're comfortable that the virus is being suppressed well and the immune system will get better. But it does vary a lot in how long it takes to get better. And I know I've had patients who take a long time to get better, long time meaning years. And some of those people probably started at a very low number. You know, some of those would be the people who, when they got diagnosed, had fewer than 10. They don't bounce back as quick in some cases. But I'm not, that I can think of, seen somebody whose viral load or whose CD4 count goes down and stays down on a set of medicines that's working well on the virus. It generally will come up. It's just a matter of time.
Any other questions for Dr. Lindley?
Yes, ma'am.
What about the statistics, females versus males? What are the statistics? Preferably the black female.
Okay. In other parts of the world, mostly resource-poor countries of the world, it's roughly equal between male and female, and most of the transmission is by heterosexual sex. And so in those areas, men and women are equal in numbers having the virus. And the United States and Western Europe and some places like that, there are other risk factors that make males more common than females. So it depends a little bit on the location. It is true that most women get HIV by heterosexual sex. You can get it from injection drug use and a few other ways, but most women get it by heterosexual sex, and men still have other risk factors that may cause them to become infected.
All right, thank you, Dr. Lindley. And on behalf of Future Builders, we'd like to award you with a certificate
Thank you.
and a small token of our appreciation.
Thank you very much.